So, modernising the NHS. Just a quick introduction to us. So Unity Insights is a social enterprise providing evaluation, appraisal and health economic services across the UK and internationally. We're a partner to Health Innovation Kent, Surrey, Sussex, and have lots of key partnerships with other health innovation networks. And we work with industry and academia to enable the spread and adoption of innovation across the NHS. Mike?
Introduction to ourselves. So I'm Mike Long, lead analyst at Unity Insights. I've been here just over 6 years now in the evaluation and analytics function. A lot of my projects that I'm involved with involve a lot of health economics, a lot of trying to demonstrate impact, and work a lot across digital and AI.
And I'm Cameron, I'm an analyst at Unity Insights. I've been here since early 2023 and I'm a bit of a jack of all trades. So what are the challenges actually facing the NHS that mean the NHS needs to modernise? So these top four that are listed here are explicitly mentioned within the new government's manifesto. So outdated technology, 48% of NHS trusts have a CT or MRI scanner in use past the recommended lifespan, which is typically about 12 years. So you'd expect at some point in the near future these might start collecting defects or they're simply outdated. There's also an insufficient supply of these diagnostic tools. So the UK has fewer CT scanners per person than any EU nation. And this has led to long waiting lists for elective treatment, which have tripled in the last decade to about 7.7 million people on waiting lists. And that's culminating really in late cancer diagnoses. So 45.5% of all cancer diagnoses are diagnosed at stage 3 and 4. We've also got problems with staffing in the NHS. So only 32% of staff report there being enough staff within their practice or service, and only 47% state that they are able to meet all of their demands at work. And this is leading to considerable staff burnout, where 43% of staff feel worn out by the end of their shift, and 42% have felt unwell from work-related stress this year. So really, there's these two problems with insufficient and outdated technology within the NHS, and also tangentially, there's understaffing, which is leading to staff burnout and workforce issues. A key piece of context to consider at the same time is that there's a push to move healthcare from the hospital into the community and closer to home by the government. And the rationale for this is that hospital-based care tends to result or be a symptom of later diagnoses, so conditions getting caught later along their lifespan, and a subsequent higher treatment costs that are associated with the increased complications of these later detections. So the rationale is that by moving a lot of healthcare resourcing into the community and closer to home, into primary and community care, is that a lot of these conditions will get caught earlier, there'll be earlier diagnoses, at which point there is a much lower associated cost of treatment and also a higher quality of life for the patient. And this is quite interesting because if we're trying to move a lot of traffic away from the hospital and towards the community, there's already people that are needing hospital treatment because they're already being diagnosed at a later stage and requiring that more intensive treatment. So as we move resources into the community, there's going to be an inertia or a delay before we see those benefits get transferred in terms of cost into secondary care. So here's how the current government is seeking to modernise the NHS and mitigate some of these challenges. Firstly, there's the Fit for Future Fund, in which the government aims to double the number of CT and MRI scanners across the NHS. And they're also looking for them to be in really tip-top technology, very modernised. So they're state-of-the-art with embedded AI technologies within. And there's also the NHS Innovation and Adoption Strategy, where the government aims to partner with industry and academia in improving procurement of new technology. So there's two sides to this, really. It's firstly increasing the amount of or improving the level of technology in the NHS, and also the associated challenge with getting it from innovators actually within the healthcare system. So now I'll hand it over to Mike to talk about what an evaluation is. Mike, you're muted.
Thanks. There's always going to be one. We obviously need to drive this innovation and technology into the NHS, but we can't just throw money at interventions, try and bring them in without actually looking to see if they work and provide value. Technology and innovation is often assessed in those controlled environments. It doesn't usually have that exposure to real world scenarios with real staff, real patients, real NHS systems. Essentially, the evaluations seek to gain that future and further insight into whether a solution has worked as expected. We look at sort of various elements which ultimately affect the impact of the healthcare system. The idea is to generate the right evidence to inform that decision making and lead to that increase in spread and adoption of the technology across the NHS and other systems. Next slide. So what are the sort of elements we're looking at when we look at to do the evaluation? You can see here, one of the main things is actually accepting new technology. It's having that trust. So here's some sort of questions sometimes to ask as part. Do patients and staff actually like the intervention? Are they going to use it? Does it contribute to the good and social good? And does it feel safe? Is there that trust element? Then there's the effectiveness. Does it actually set out what it needs to do? Obviously, things, as I mentioned before, in controlled environments often do, but when you bring them into the NHS, when you bring them into that real world environment, sometimes you need to show that replicability of it. Another element is around the implementation. Is it actually going to set up properly and be working properly in terms of, does it integrate in the existing architecture, whether that be data systems, whether that be processes that are already in place? Is it going to function as expected within that architecture? Another big question which always comes up and is actually usually the sort of main question is the value. Once you bring it in, is it actually going to return positive, a positive economic outcome? Whether that be patient outcomes, whether that be staff efficiency gains, that value question is always asked. And another element here we've got is the inequality and data bias. So is this intervention going to come in and is it looking to address an inequality, or is it actually going to make it worse? That's something that needs to be assessed, especially if it's something around diagnosing risk factors, things like this, because it might just create a larger disparity between different socioeconomic groups. How do we go about doing this? Well, there's lots of different ways in evaluation, but I've got some key ones here. We'll look further along in this workshop, in this session, to look at some examples. But here we've just got qualitative analysis and quantitative analysis. So qualitative, obviously looking at the views of patients, the views of staff, getting more of that impact from that kind of soft evidence perspective. And then the quantitative is obviously the numbers, the figures, comparing the sort of A/B analysis to see if something is changing compared to the baseline, understanding what it looks like compared to a counterfactual. You often use these together, so that's what we'll call a mixed method study. Usually the qualitative provides that context as to why we're seeing the particular impact that we're seeing. Again, we've got health economics in there, which supports that value statement and the inequalities assessment.
So just a word on why you can trust us and why we're an authority on these topics. So Unity Insights has a lot of expertise in working with digital technologies and evaluating digital technologies. So many of the innovations which make their way into the NHS these days are centered around the digitalization of existing processes with the aim of moving from analog to digital to make these processes more efficient and kind of reduce the workload on people, taking some of the strain out. And a lot of case studies for this are available on our website. And also, we helped write one of the books about it. So the AI Award from the NHS provided funding to complete evaluations of AI technologies in healthcare settings. And Unity Insights was one of a number of parties that were commissioned by the NHS to write a learnings document which summarised key learnings from these evaluations. So now we're just going to move on to a few case studies in which we're going to explore some different digital and AI technologies which we have evaluated over the years, which provide a lot of promise in alleviating these issues that the government is seeking to target that we explored earlier. And along the way, we're going to explain how the activities that we did can help these solutions make their way further into the NHS. So firstly, here's a technology called Derm by Skin Analytics, which is an AI-powered skin lesion analysis tool for urgent suspected skin cancer pathways. So what are the issues at hand, firstly? Dermatology services are really quite inefficient in terms of the referrals that's been put through them. So 60% of dermatology service referrals in England are on the urgent suspected skin cancer pathway, but only 6% of these are converted to a confirmed skin cancer case. This is partly because a lot of people will go to, say, a GP for examining a skin lesion, and out of an abundance of caution, the GP will put them on an urgent referral case just to make sure that they don't have any sort of skin cancer. NHS operational targets are 93% of referrals to be seen within 2 weeks. And in the 22-23 financial year, only 80% of this was achieved. So there's a lot of excess patient waiting for a result, which can contribute to anxiety. Only 63% of patients receive treatment within 18 weeks of referral, and approximately 1 in 3 patients with squamous cell carcinoma or melanoma are not referred on an urgent cancer pathway. So you've got these two issues mainly here, which are many non-urgent cases are being referred on an urgent cancer pathway, and many actually urgent cases are not being referred on an urgent cancer pathway. So to sum it up, there's considerable delays to treatment, the referral system is bloated, and it's also fairly inaccurate. So here's the intervention. DERM is a machine learning algorithm which analyzes pictures taken of skin lesions using a bit of technology which is attached to really a phone camera called a dermoscope, which is for magnifying the skin lesion. And it analyzes pictures of these skin lesions, and it can identify 11 types of lesions, including malignant melanomas, squamous cell carcinomas, and basal cell carcinomas, which account for the vast majority of all skin cancers. And it's suggested to achieve a sensitivity and specificity of diagnosis comparable to dermatologists and outperforming GPs. And the process at which this happens is that images are taken at a community hub using a dermoscope and a mobile phone. The algorithm analyzes these photos and identifies possible skin cancers, which in turn improves the accuracy and efficiency of triage and the referral system. So here's the project overview. We were commissioned by the Department of Health and Social Care to do a mixed methods evaluation. This was a combination of quantitative findings, which looked at the performance of the intervention and any subsequent health inequalities, qualitative findings, which concerned the safety, effectiveness, acceptability, and sustainability of the intervention, health economics, where lots of different models were pursued in terms of kind of quantifying the pound sign benefit or gain versus the cost of the intervention. There was a machine learning principles review, which examined whether the technology was developed in accordance with existing best practice standard guidelines for developing AI technologies within healthcare. And these were summarized within an interim report partway through the evaluation and a final report at the end. So firstly, onto the quantitative analysis results. So DERM demonstrated high sensitivity, which is correct identification of positive cases. And that resulted in a reduction in unnecessary referrals by discharging low-risk lesions from the urgent cancer pathway. So immediately it was removing some of the unnecessary traffic from the urgent cancer referral pathway. In terms of the qualitative analysis, you might have thought, or you would be forgiven for thinking, that people would have been quite uncomfortable with a bit of AI technology having the last say on whether they were referred. Hangover from the COVID pandemic was that there's a higher proportion now of GP appointments being conducted via the telephone, and that's reduced patient satisfaction with primary care. But surprisingly, patients viewed this AI technology and AI-enabled teledermatology very positively. Patients were uncomfortable about the use of, few patients were uncomfortable about AI being used for their diagnosis, and most patients appreciated the value of AI in decreasing waits for appointments. So presumably this was reducing their anxiety. So both this quantitative and qualitative analysis provided a strong evidence base for the effectiveness, the clinical effectiveness of the intervention, and also how likely it was to be accepted by patients. Moving on to cost-benefit analysis. Those numbers at the top there, 1.7 and 1.1, are what are called the BCRs, which are the benefit-cost ratios in different implementation scenarios. So these numbers represent how many pounds are returned for every £1 spent implementing or running the intervention. So in every implementation scenario that was explored, the implementation of DERM resulted in a greater monetary benefit returned than the associated cost of implementation. So implementing DERM would actually result in a monetary gain. For the cost utility analysis, and for those that are unfamiliar with the cost utility analysis, this is specifically exploring the monetized improvements in quality of life amongst those affected by the intervention. So some sites demonstrated a higher cost and worse health effect, with others demonstrating a lower cost and better health effect. So this kind of showed that identifying the best implementation model is absolutely crucial. These AI and snazzy digital technologies aren't really just a catch-all, work in absolutely any scenario technology or remedy. There needs to be work put in terms of identifying exactly how it should be put in and where it's appropriate and where it isn't. As far as the impact of the evaluation, the findings of the evaluation that were conducted have been used to inform further rollout of the technology across the NHS, such that it's now being piloted in 9 additional trusts as part of the NHS Cancer Programme. And in terms of the issues we explored earlier, it has the potential to shrink those waiting lists and replace existing diagnostic technology for skin lesions. It's also worth referring, sorry, Mike, that there is a Q&A function. I forgot to mention this earlier. At the top of your screen, there is a Q&A function. So if you have any questions, please use that function to ask them, and we will come to them at the end of the presentation. But for now, I'll hand over to Mike to talk about Bleeper.
Great. So this was another project that we conducted. Bleeper, essentially a digital referral system. So the context of this is there's a lot of paper-based referrals at the moment within hospitals. This is within particular specialties, but also across specialties. The time taken to write out referrals, to submit them, and for them to be reviewed and actioned is quite burdensome. Essentially, on top of that, there's telephone discussions that happen between a referee and a responder. Often this is not documented in a detailed manner. It does result sometimes in certain information being lost, communication being a little inefficient. It does result in referral delays. That missing information can also create a greater length of stay than it should be for patients not receiving their care quickly enough. So in comes Bleeper. Essentially, it looks to digitalize all that communication and all that information between clinicians, between nurses, between consultants, and it essentially creates that platform for all this information to be stored in one place when it comes to the communication. It looks to create a lot more efficiencies when it comes to the time taken to communicate, and also ensure that patients can receive their treatment quicker with those response times improving. So what are we looking to do as part of the project? Well, first of all, we looked to assess the technology against the NICE evidence standards frameworks, just to understand the type of evidence that would be required. And then we looked at some of the quantitative analysis. So this was mainly looking at those key figures of time taken from submission, how much the app was being used, but also we wanted to understand the acceptability and whether staff wanted to use it, and it was actually going to be used as expected. We also wanted to understand whether the technology was worth implementing from a value perspective. As Cameron went to in the last project, the Derm project, this was really important just to understand whether that output, the benefits were going to be greater than the costs. And this was all presented in a final report. So some of the results, essentially with all the data being collected, it was quite easy because it was collected within the app itself, but also we had some good buy-in from the Northern Care Alliance where it was adopted across Royal Oldham Hospital and Fairfield, across these different specialties. That buy-in was really useful to be able to get that data and compare a baseline compared to what Bleeper was showing. So one of the key results is that actually the clinical response time improved by over a day. So that's from the submission of a referral to the response of it, and therefore a patient receiving their care. So that was really a large improvement, which we understood did result in some length of stay being reduced, which we know is a large cost in the NHS. In terms of the actual communication efficiency element, staff on average saved around 4.4 minutes per that communication, per that referral, which when you add up the amount of referrals there were, we're in thousands now, that all adds up, and that clinical time is then released for other things. So when we come to monetize everything, we can see that this produced a positive return on investment. So we had a net benefit just during the pilot period of over 350k across NCA, producing a good solid benefit cost ratio of 2.7 pounds for every £1 spent. We then looked to see what would happen if it continued to be used in the same manner across a 5-year period. Again, that produced some really positive results. But then also at scale, it was modelled and showed some really positive returns if it was to be spread and adopted across the whole of Manchester, Greater Manchester ICB over that 5-year period. So we know the figures were good. So what happens when it came to the perceptions from staff? I think these results are really positive. It demonstrated that acceptability and the appetite to use the system itself. I think everyone recognised the benefits of it that it brought. And so all of this kind of coincided with the figures that we saw in the quantitative analysis. I think there was that perceived sort of perception from staff that it did improve the quality of patient care, which was really positive to see. You can see those numbers are pretty large, but actually it wasn't all, yes, let's keep it exactly how it was. I think the point of evaluation is sometimes to identify where it can improve as well. So there were some recommendations that came out of a lot of the surveys, a lot of the questionnaires and interviews that we conducted. A lot of it was enhancing the usability further of Bleeper itself, whether that be different features, different functions, improving functions. You can see there's some small things here that just made life a lot better when using it. Another recommendation that we had was obviously to continue the collection of the metrics and the KPIs to ensure that it continues to be used and is as effective as we saw in this evaluation. Another thing was to understand how it was or could be used across other specialties, just to understand whether there's certain specialties which it's utilised more so in, but also because this was just conducted in secondary care, we thought, well, what happens if you introduce it into primary and community care where there's referral systems in place? Are those same benefits going to be realised? Which is why it's quite important for this particular workshop, this particular presentation, is just to understand whether something in secondary care can be introduced into primary care and community care, for the reasons Cameron discussed earlier. So what did it actually lead to, this evaluation? Obviously, there's some very positive feedback there from the Chief Clinical Information Officer at the NCA, but Bleeper went away and actually adopted a lot of the recommendations that we suggested, improving the functionality, adding a lot of other features to it, and that made it more appropriate for the use in other parts of the system, such as the introduction into a community diagnostic centre in NCA, which is underway at the moment, and I'm only just recently aware that they've actually introduced it into a CDC for a breathlessness pathway, quite local to me, which was great to hear. So a lot of the evaluation has led to the spread of and adoption of this technology, not just in secondary care, but also in primary and community care.
So as our third case study, we're just going to blast through quickly Rapid Health Smart Triage, which is an automated triage system for primary care. So what are the issues at hand? Satisfaction with access to primary care remains quite low because GP appointments are typically booked on a first come, first served basis. We're all very familiar with how frustrating the 8 a.m. rush is to try and get a GP appointment. But beyond how frustrating it is, it also leads to an inequitable distribution of care where these appointments aren't handed out on the basis of urgency or need. More GPs are describing their workload as unmanageable and are opting to retire early. And this will be because the BMA, the British Medical Association, states that a GP must have no more than 25 patient contacts per day to allow for safe care delivery. But on average, they have 37, which greatly exceeds the suggested limit. So to summarise, the problems at hand are inequitable treatment, low satisfaction, and unsustainable workloads within primary care. So what is Rapid Health Smart Triage? It's a UKCA marked triaging system used in approximately 100 practices across the UK. It's intended to streamline appointment booking, workflow management, and appointment allocation based on staff capacity and patient clinical need. Essentially, what happens is patients fill in a request form online for an appointment in which they state their symptoms or needs. This is assessed by the technology and it also considers the urgency of the request and also the clinical capacity available to address it. In doing so, it either allocates or allows the patient to self-book an appointment, and this is intended to lead to a more equitable or efficient allocation of appointments in primary care. So to summarise, here are the problems. Difficulties accessing GP appointments because of the 8 a.m. rush and that inequitable distribution of appointments. High GP workloads in trying to meet 37 contacts a day, and there's low patient satisfaction and unmet need in the process of booking an appointment. So how to remedy this would be to improve the experience of care access, streamline GP workloads, and end the 8 a.m. rush. And in doing so, the solution to this would be allowing patients to access care 24/7 and shorten waits rather than having to rely on phone lines which are only available when a front of house administrator is at the practice. It can be this request can be sent in at any time of day, and also allowing for triage based on the urgency of the request. So here's the project overview. We were commissioned by Health Innovation Kent Surrey Sussex to conduct a mixed methods evaluation. We did quantitative findings in terms of looking at the performance and effectiveness of the intervention in doing what it set out to achieve, and qualitative findings as well, which also considered effectiveness in terms of how effective it was as reported by patients and staff, and the acceptability among these cohorts as well. And this was all summarised in a final report. So the methods we used, quantitative insights. So this was mainly based in data that was extracted from the system, which contained lots of information to do with kind of technical information and behavioural information in terms of understanding how users interact with the platform, the subsequent actions taken by the smart triage system, and what the subsequent changes in care activity were. We also did qualitative insights. So this was data gained from patient and staff surveys to gauge opinions on using the innovation and perceived benefit. So experiences from those that were impacted by the pathway change. So why did we do this mixed methods approach? So quantitative insights enable the understanding of trends such as peak times for care requests. It's about understanding many of the clinical and procedural benefits of using an intervention, the qualitative insights, on the other hand, provide a deeper understanding of how the new system impacts both staff and patients. So it's more about understanding experiences among those who experience the effects of an intervention or who are implicated by its introduction into the healthcare system. And these are both really important for understanding how likely, how effective an innovation being introduced into the healthcare system is likely to be, which can help provide a use case for it and spread its adoption across the NHS. So here are the results. Firstly, improved staff experience. So 91% of appointments booked by Smart Triage were booked without any administrative or clinical input. So this massively reduced the load placed upon administrative staff at the practice. Only 18% of patient requests were initiated over the phone, down from 88%. So this also is symptomatic of a improved staff workload for administrative staff. And the proportion of on-the-day appointments fell from 62% to 19%. So this really shows that in terms of streamlining the workload for GPs, it made their workload in terms of appointments and patient contacts a lot more predictable and a lot more smooth rather than undulating day to day a lot. As far as patient experience, the median patient waiting time reduced from 13 days to 4 days. So patients were being seen a lot faster. There were 47% fewer phone calls at 8 a.m. So already that's a large part of the 8 a.m. rush just eliminated. And patients found the system easier to use versus the previous appointment booking system. So that overall experience of actually getting an appointment was greatly improved. And here's the impact of the evaluation. So Smart Triage shows a lot of promise in helping the government to deliver a modern booking scramble. Deliver a modern booking system to end the 8 a.m. scramble, as was proposed within the government manifesto. And it demonstrates a lot of potential to improve the patient experience of primary care, handle increased pressure on primary care as a result of moving healthcare activity away from hospitals and into the community, and improve workforce satisfaction and workload. And now I'm just going to hand over to Mike to do the key takeaways.
Great. So I guess just to sum up a lot of what we've been discussing is the first thing is obviously identification of those key areas that are requiring the improvement, those bottlenecks, those processes, those inefficiencies that exist currently. A key thing is around the access. It's the appropriateness of this new technology, AI systems coming in. Is automation actually suitable? Is there a risk? Is there a limitation that it's going to bring if it is brought in? That implementation is then really important. The integration into the current systems. We can't forget that humans still exist when we're implementing. Are they still going to be accepting it? Are they going to be using technology as expected? Or can these systems, can these processes and pathways be improved without the use of things like AI and digital? So all that needs to be considered along the way. Are we replacing something, or are we just complementing something that already exists within the pathway? And finally, how do we know that these new interventions have worked? We need those key measurements for success, essentially for the evaluation, and we do need to continue to monitor to understand that it's still working as expected. Finally, we need to modernise the NHS. New innovation needs to come in, especially digital and AI. That will help us achieve this. However, we do need to critically analyse and evaluate to best understand the impact of such. And that evidence base that we generate through evaluation can help us inform those decisions, lead to optimising the adoption of new technology within the NHS. Finally, this will help us achieve those better staff and patient outcomes. So evaluation is essentially the bridge between that new technology and this spread and adoption within the NHS. Thank you very much, everyone, for joining us. Happy to welcome any questions, whether that be in the Q&A function, or if anyone wants to throw their hands up and ask us any questions. We're going to be here for another 5 or 10 minutes to happily answer any questions.
Also, just once again, advertising the rest of the workshop series. So yes, thank you everyone for attending. This was the seventh in our workshop series. The next workshop will be on the 29th of January. That will be our Power to the Patients workshop. And then after that, the next one will be on the 19th of February, the Ensuring Patient Safety in the NHS workshop. All of our previous workshops were recorded and can be found on our YouTube channel. And thank you for listening. Please ask some questions. And also, if you want to get into contact with us or find out more, you can go to our website. There's our Eventbrite, which has the links to sign up for all of the other workshops. There's our LinkedIn, and you are also able to book a one-to-one meeting with our team.